This is a presentation on sleep apnea and surgical advancements. We also hope to discuss a combined specialist sleep clinic that we have in Mornington Peninsula for sleep patients. Some of the new surgical techniques include barbed reposition pharyngoplasty, as well as new tongue reduction techniques called coblation of the tongue. These techniques have improved the outcome and reduced the adverse effects of surgery. We discuss these cases and our results at the end. Apnea is cessation of breathing for up to 10 seconds, whereas hypopnea is reduction in breathing. The number of events per hour is calculated, and if it's significantly above 5, it can have adverse health effects. This condition is once thought to be only present in about 2 to 4% of people, but now we know it's significantly more prevalent and may cause significant health adverse effects unless treated correctly. The best management involve a good method of assessment. This would be done with both a respiratory physician and an ENT surgeon. We do this in a monthly combined sleep clinic in the Mornington Peninsula. The aim of the assessment is to determine the severity of sleep apnea, then to look at the symptoms and sites of obstruction. Sites of obstruction is determined by a full assessment including endoscopy. Once we know the sites of obstruction, we will discuss potential management techniques, including surgery if surgery is suitable. Then we will take the patient's wishes into account and go through a possible management plan, including non-invasive methods. The assessment pre-consultation include getting a sleep score called Epworth Sleep Score, as well as getting a sleep study, preferably prior to a clinic. During the clinic, we will assess the structure, the nasal airway, as well as look for multi-level obstruction at the level of the palate, which is back of the throat, the tonsils, the tongue base, as well as closer to the voice box area. Once we assess, then we will classify depending on the size of the tongue and size of the tonsils. Once we know the size of the tongue and the tonsils, we will stage them. For example, if a patient has large tonsils and a less bulky tongue, they would be stage 1. If they have significantly bulky tongue with small tonsils, they are more difficult to treat and will be staged higher. Stage 4 is when someone's body mass index is over 40, which makes surgery more difficult and less predictable. Thereafter, we'll do endoscopy. We will look at the airway and determine the sites of collapse. The sites of collapse include the velopharynx, which is the soft part of the palate, the tonsils and the side walls of the throat, the tongue base, and the epiglottis. And we determine these areas by getting the patient to breathe out and looking where the collapse occurs mostly. Once we have most of this information, we can start making decisions and discussing management techniques. This part of the presentation discusses mainly surgery, whereas Dr. Mulder's talk will discuss non-surgical options. With regards to surgery, we look at the anatomy. We look at the sites of blockage, and then we decide what type of surgery may suit the patient the best. We always offer CPAP or non-surgical methods as other options, as well as positional devices, etc. as well. If a patient wishes to undergo surgery, the aim would be to have a successful outcome. Success would be defined as bringing the apnea-hypopnea index to below 20 and reducing the events at least by 50%. Hence, the ideal operation should be having a high success rate. In other words, bringing the patient into a level where they do not require a machine or a device longer term. It should be easier to perform with less comorbidities or bad health outcome, and it should be reproducible and predictable. It should have a long-term outcome. It should complement any other options that's available. In some patients where CPAP may not work, they may benefit from surgery along with the machine. It should not affect the use of the machine. It should complement the use of the machine. It should be economical in the long run. So this is what we do. First, we determine the sites of obstruction. If the obstruction is at the velum, this is a view of the soft palate from the nose going towards the mouth or the airway. If it's collapsing, we do modified barbed reposition pharyngoplasty. We will call it BRP, and that is aimed to open that area. And if the collapse is at the tonsil level or the side walls of the pharynx, called the lateral walls of the pharynx, once again, tonsillectomy and modified BRP improves that area. If the collapse is at the hypopharynx, essentially at the back of the tongue, due to tongue bulk, we do coblation of the tongue and what we call lingual tonsillectomy to try and improve the bulk or reduce the bulk and improve the airway. So essentially what we do is a multi-level operation which aims to improve the overall outcome but hopefully keep it not significantly invasive. This shows some images of modified barbed reposition pharyngoplasty. As you can see, the tonsils have been removed and we swing a muscle of the back of the throat across to try and open the airway. The next image is even clearer on what happens. In this, you can see a patient with enlarged tonsils. And if you look at the image in the middle, the tonsils have been removed and there is a sufficiently open airway. And if you look at the blade that's on the tongue and the airway, it's about the same size. Then you do the technique called barbed reposition pharyngoplasty. It improves the upper part of the soft palate by almost 2.5 to 3 times, as well as brings it forward, which you can't really appreciate on the third image. So if you look at the first image and the third image, there's a significant difference. In fact, there's a significant difference between the middle and the last image as well. In addition to that, we do tongue channeling, which is little channels put in the tongue to debulk the tongue or reduce the size of the tongue. And this is less invasive than some of the open procedures done in the past. So by combining the two, which is modified barbed reposition pharyngoplasty or BRP along with tongue channeling, essentially we are doing multi-level surgery. And in addition, we also may perform nasal surgery to maximize nasal airway. This is purely a surgical aspect. There's a non-surgical aspect that Dr. Mulder discusses separately in another talk. Now, we have done some research on early outcomes of our patients. There were 17 cases and there were 2 groups and 13 patients were followed up and the others' results were still pending. The first 8 had both done, which is barbed reposition pharyngoplasty as well as tongue channeling. And the last 3 only had 1 done, but not both. If you look at the red box on the side of the blue columns, you can see the final AHI or final events per hour. They have dropped to below 20 in all of the cases, and most of them were above 20 and some of them were well above 20 to begin with. So essentially we managed to bring their events sufficiently down to avoid use of a machine longer term. These patients either had trialed a machine or declined use of a machine, and machine has always been offered to all of our patients. Whereas when they underwent only one procedure but not tongue channeling, their outcomes were not as good. So essentially, the green blocks show the improvement in the patients, which was significant. In fact, overall, in the 8 patients who underwent both procedures, the reduction of events were 70% or 68%. Overall, in the 8 patients who underwent both the procedures, which is BRP and tongue channeling, did not require a machine following surgery. In conclusion, these early results are very promising, but we hope to do a longer term follow up and study and also look at long term outcome. If you require any sleep study forms, it's available on this blog as well as Dr. John Mulder's website. And if you require any other information, we are happy to be contacted. Thank you.